Hello, my name is Mark Haber and I'm a Clinical Associate Professor at the University of Wollongong and a shoulder surgeon. I'd like to invite you to visit my website at so.com.au to find further information about these talks. I work out of a number of clinics around Sydney, including Southern Orthopaedics in Wollongong, south of Sydney, Campbelltown Private Hospital, and a number of clinics in Sydney, mainly based on the North Shore. These include Macquarie University Hospital, Dalcross Hospital in Killara, and Lady Davidson Hospital, Turramurra, and also in Brookvale. I will present a series on instability of the shoulder joint, and in this part, multidirectional instability. A little on the history. It was Neer and Foster who are widely credited for bringing the clinical attention to the condition of multidirectional instability of the shoulder joint. In a paper in 1980, they presented inferior capsular shift for involuntary inferior and multidirectional instability of the shoulder joint. When we talk about instability of the shoulder joint, we describe the shoulder as having dynamic and static stabilizers. These static stabilizers include the bony anatomy with the glenoid socket, and this glenoid socket version is determined by the shape of the scapula. There is the overlying cartilage, and then surrounding that is the labrum, which is Latin for lip. So in diagrammatic form, we have the static stabilizers, including the glenoid bony cavity with its relevant version and the overlying cartilage. Added to that is the labrum, which adds more depth to the socket, and also adding stability are the capsule and ligaments surrounding the shoulder joint. We also have dynamic stabilizers, which include the scapulothoracic musculature, the rotator cuff, and proprioceptive and neuromuscular control. Combining the bony cartilage and ligament anatomy and the tendons, muscles, and ligaments provide stability to the shoulder joint. The dynamic and static stabilizers are able to compensate for other deficient structures. Structural deficiencies become apparent only when compensatory mechanisms fail, such as labral tears and damage to the overlying cartilage and bone. Shoulder instability is not the same as joint laxity. Defining multidirectional instability is difficult. Standardized criterion do not exist in the literature, which results in variations in the prevalence of its diagnosis. We have to differentiate between joint laxity versus instability. Instability is characterized by the presence of symptoms in conjunction with abnormal laxity, and is indicative of deficient static and dynamic glenohumeral joint stabilizers. Instability can be caused by repetitive microtrauma or a single macrotrauma. Congenital hyperlaxity may predispose to development of shoulder instability. Traditionally, we used to speak of shoulder instability divided into two categories, the TUBS and the AMBRIs, with the TUBS with a traumatic unilateral instability often associated with a Bankart or cartilage lesion on the front of the shoulder joint and require surgery, and the other one was AMBRI, which was atraumatic multidirectional, often bilateral, and treated with rehabilitation, and if it comes to surgery, the inferior capsular shift. But these classifications on etiological terms often do not help. A more modern classification of dynamic instability by Gerber and Neiffeler describes either unidirectional or multidirectional instability with or without hyperlaxity. We can define multidirectional instability as symptomatic instability in two or more directions with or without associated hyperlaxity. So the unidirectional instability without or with hyperlaxity So as we mentioned, multidirectional instability without hyperlaxity is often associated with anterior and posterior capsulolabral lesions. These labral lesions or labral tears are either in the front of the shoulder joint and we call them Bankart lesions, or the superior aspect and we call them slap lesions, which will be part of other talks. And if it's in the posterior aspect, they don't get a name, they're just called posterior labral tears. So in this example of a patient with multidirectional instability without hyperlaxity, we could see significant capsulolabral lesions. So the arthroscopy demonstrates on the inferior, anterior, and up to the superior aspect of labrum, diffuse labral tearing. In the posterior aspect of the labrum can also be torn. Moving the shoulder joint demonstrates marked multidirectional instability without obvious dislocations. The capsule is somewhat loose and voluminous and can seem to be quite inflamed. When we start to repair the capsule and ligaments, we can see how lax the capsule of the shoulder joint is from multiple episodes of subluxation. Capsulolabral lesions. They presented 20 patients where the inclusion criterion was a painful shoulder with lesions indicative of instability. However, their exclusion criterion was recognized instability. Pain was reproduced with the arm in an anterior apprehension position and relieved by relocation test. However, no actual apprehension or feeling of instability was experienced. They concluded that UPS is often missed and is important to consider in the young hyperlax athlete, and arthroscopic techniques can lead to predictable good results and return to sport. When we talk about clinical presentations of multidirectional instability, we have to understand there is a spectrum of instability patterns. Most patient presents with an insidious onset with non-specific activity with related pain, which often occurs in the second to third decade of life. Clinical suspicion is essential for the accurate identification of multidirectional instability. An accurate physical examination is also critical for adequate treatment of patients with multidirectional instability. When we examine the shoulder joint thinking about multidirectional instability, we have to evaluate generalized hyperlaxity. Typical signs of generalized hyperlaxity include elbow or metacarpophalangeal joint hyperextension, knee recurvatum, patellar instability, and one of the classic features, ability to place a thumb on the ipsilateral forearm. Shoulder laxity has been clarified with the Byton score, which has 5 components. These being elbow hyperextension beyond 10 degrees, thumb to radial border of forearm, extension of the little finger beyond the metacarpophalangeal joint beyond 90 degrees, knee hyperextension beyond neutral, and being able to touch the flat of hands on the ground. When we look at stability tests, There is the sulcus sign, the assessment of anterior and posterior instability, which can be performed either sitting or lying, and the anterior apprehension test, which can also be a test of posterior apprehension, where pain is elicited on pushing the shoulder joint either anterior or posterior. Here's an example of, on the left-hand side, maximum abduction external rotation, which may result in apprehension, and compressing the shoulder joint backwards may reduce the apprehension and relieve the feeling of instability. That is a positive test. The O'Brien's test is also extremely valuable, especially for superior and posterior labral pathology. An example of multidirectional instability is a 19-year-old netball player I recently saw in the rooms with increasing pain and the inability to continue playing her sport. Taping of her shoulder joint has provided good short-term benefit, but unfortunately physiotherapy has not provided long-term relief and ability to return to sport. Clinical features are somewhat subtle, with only mild elbow hyperextension and thumb not quite reaching the forearm. Examining the shoulder joint, however, demonstrated significant anterior apprehension. So the arm in the position of maximum abduction external rotation, pushing forward created pain, whereas pushing back did not. Forward movement of the shoulder joint increased her pain without any obvious features of instability. O'Brien's test was normal. The MRI of this lady demonstrated a somewhat voluminous capsule, but no obvious labral pathology. So in our classification, she falls a bit between the lines, but with signs of multidirectional instability with hyperlaxity, with a patulous capsular tissue, some signs of general hyperlaxity, and no labral tears. When we look at the outcomes of surgical management, the early procedures of open inferior capsular shift, the return to sport results were less than optimum. In a series by Altec, multidirectional instability treated with a modified Bankart procedure demonstrated an 80% return to sport, with a decreased throwing velocity even at 3 years. Pollock did a series of inferior capsular shift procedures, with a 70% of patients were able to return to pre-morbid level of sporting activities. These findings emphasize the importance of counselling of patients regarding their expectations of returning, especially to elite sport, especially throwing. Gartzman in 2001 did a series of arthroscopic treatment of multidirectional instability with a 2 to 5 year follow-up. He demonstrated 94% patients had good or excellent results, with 85% returning to their desired sporting levels. So return to sport may be superior in properly selected patients who undergo arthroscopic treatment of multidirectional instability, but patients must still be warned about their ability to return to elite levels. Postoperative rehabilitation for multidirectional instability. Each protocol should be individualized and based on the direction of primary instability and especially the robustness of the repair. The shoulder is placed in a neutral rotation brace for 4 to 6 weeks, with or without an adduction pillow. We do not routinely alter the position of the immobilization based on the direction of multi-instability, and a conventional shoulder immobilizer is recommended. Multidirectional instabilities rarely have difficulty regaining motion. Therefore, we individualize the immobilization period based on the factors mentioned above. In this population of patients with multidirectional instability, we prefer to immobilize the shoulder for at least 4 to 6 weeks. Therapy should be initiated if the shoulder becomes stiff, which, as I said, is quite rare. If the glenohumeral joint remains supple, longer periods of immobilization can be used, but I would not usually exceed 6 to 7 weeks. However, patients are instructed to perform elbow, wrist, and hand motion exercises. After the immobilizer is removed, the patient can begin a strengthening exercises without any need for significant stretching. Regarding to return to full activities, we usually run approximately 6 months post-operatively if they demonstrate full strength and complete a sport-specific training program. However, I would recommend 9 months before return to full activities in your high-risk patients, especially associated with high-risk activities.